So thank you very much to Dr. Rajita, Dr. Meena, and the entire organizing team for this opportunity. I'm going to talk about two common procedures that are done for children with cerebral palsy. So the first is the gastrocnemius recession, which is an extremely common operation. This is typically done in children with bilateral cerebral palsy or diplegia. It's important not to operate for spasticity. Spasticity will reduce by the age of about 7 years, and gait also matures by the age of 7 years. So do not operate on 4-year-old toe walkers, because those children need non-operative measures like botulinum toxin injection, splints, and physiotherapy. So these operations are meant for the older child where they have a problem with contracture. And if in doubt, do not operate, because if we over lengthen the calf, then it causes significant problems later in life with the onset of crouch gait. But even appropriately performed gastrocnemius recession will weaken the calf. So it is a bargain that we are making in that we are allowing the calf to become weak in return for allowing the child to have a more functional gait pattern. 3D gait labs are now available in all corners of India. So I would recommend that every surgeon who performs an operation on a walking child with cerebral palsy should obtain 3D gait analysis if at all possible, because it massively improves your comfort and the quality of your decision making. So there are 5 levels at which the tendo-Achilles mechanism, the plantar flexors, can be lengthened. Level 1 is close to the insertion. This is a ZUD lengthening or a hook. These operations should not be done in diplegics. These are mainly meant for hemiplegics. Level 2 is a Baker, which is done at the musculo-tendinous junction. Slightly more proximal are the vulpius and the stria, and I will be showing you a video about the stria. And then you have a higher level, which is on the muscle fascia of the gastrocnemius, or you can detach the gastrocnemius from its origin, the medial or the lateral heads, and this is called the Baumann procedure. So this is a video that I recorded some time ago showing the gastrocnemius recession. This is the Silver-Sciol test that we perform under anesthesia so that there is no spasticity. You can see that there is a calf contracture with the knee in extension that is abolished by knee flexion. So the skin incision is just made where the gastroc muscle belly is seen to gradually disappear into the fascia, 2 fingers breadth posterior to the posterior border of the tibia. This is a fairly safe corridor, so one can use sharp dissection and incise the deep fascia of the calf in line with the skin incision. So once we go through the deep fascia, we use finger dissection to sweep the loose areolar tissue between the deep fascia and the gastrosoleus aponeurosis that you can see. That's the silvery white fibers of gastrocnemius aponeurosis, and then more medially, where my knife is going, you can see the soleus aponeurosis. You can see the muscle coming through, and that is the lower end of the medial head of gastrocnemius. If you want to do a more proximal pure gastrocnemius lengthening, you can get into that gap that I'm going to show you in a minute, where my knife is going. You can see that gap. So you can again dissect with blunt dissection in that gap, but I do it at a slightly lower level where the gastrosoleus fascia has already merged. And then you start all the way from the lateral border, use a retractor to protect the sural nerve that comes between the 2 heads of the gastrocnemius and goes laterally. And then you just make a single stripe directly across, but do not forcibly dorsiflex the ankle, because again, that will over lengthen the calf and weaken it. You should very, very gently extend, dorsiflex the ankle and extend the knee only up to neutral. So do not forcibly dorsiflex the ankle. So the post-op regime is a below knee weight bearing cast. Child can start weight bearing after the surgery immediately as tolerated. So I put it on for 4 to 6 weeks, 4 weeks in children less than 10 years and 6 weeks in children older than 10 years. Because the gastrocnemius is a muscle that crosses the ankle and the knee, some form of immobilization above the knee is required. So I use a knee gaiter at night time for 8 hours, and this is continued for a period of 6 weeks to 3 months. And AFO is mandatory for a minimum of 1 year post-op, possibly longer. The commonest reason for recurrence of contracture after gastrocnemius recession is failure to comply with the ankle foot orthosis. So it's very important to reinforce this after surgery. And obviously, a prolonged program of physiotherapy is required after any operation in a child with cerebral palsy. Moving on to the next procedure I'd like to discuss, this is the hamstring transfer. It's a relatively new operation which has come to the fore in the last 5 years. So this is largely amongst surgeons who perform a lot of cerebral palsy surgery. The hamstring transfer has replaced the hamstring release. So you will know that the hamstring is a hip extensor in addition to being a knee flexor, and complete release of the hamstring, even a complete medial hamstring release, causes excessive anterior pelvic tilt because its function as a hip extensor is lost. So these children after surgery, they develop lumbar hyperlordosis and lower back pain. And again, a humble plea to all surgeons to use 3D gait analysis for decision-making pre-op. If on 3D gait analysis, you find that there is a lot of anterior pelvic tilt pre-operatively, one should be extremely careful with performing a hamstring release because this will increase the amount of anterior pelvic tilt after surgery. So 3D gait analysis is probably even more essential the more proximal your surgeries in a child with cerebral palsy. So this is an example of someone who has had an over lengthening of a hamstring. This was a functional walker with a little bit of knee flexion, underwent over lengthening, percutaneous hamstring release was done, and you can see post-op that he has gone into severe genu recavatum, and you can see the amount of anterior pelvic tilt and the lumbar hyperlordosis, and these children eventually will stop walking. It's disastrous for the child because once you over lengthen the hamstring, it is irreversible. So moving on to the surgery itself, it is done in the supine position. The original hamstring transfer was described in the prone position, but we have developed a technique by which we can do it in the supine operating position. So we check the popliteal angle pre-op, and you can see that this child has a 90-degree popliteal angle. His gait showed that he had a persistent knee flexion in stance. So that's the gracilis and the semimembranosus. So the incision is between the gracilis and the semimembranosus, just above the knee flexion crease in the posteromedial aspect of the knee. These operations are done under tourniquet control just for better visualization of the anatomy. So the first muscle that I'm isolating here is the semitendinosus, and then immediately medial to that is the semimembranosus. So the semitendinosus tendon is identified, and with blunt dissection, it is isolated from its surrounding paratenon. Next, the semimembranosus is identified, and this is the gracilis. So we perform an intramuscular tenotomy of the gracilis, and then this is the semimembranosus. Sorry, the video is a little out of focus. It will come back into focus in a minute. So I'm just carefully going into the sheath of semimembranosus and identifying it. Next, using a McIndoe's, we release the semitendinosus wherever you can see the end of the tendon at the bottom of the incision. It's not necessary to go all the way to the insertion of the semitendinosus in the pes anserinus. So here you can see a clearer view of semimembranosus, and we just do a myofascial recession. Again, it's important intra-op not to do a popliteal angle. Should not repeat the popliteal angle test after releasing the medial hamstring muscles because that could overstretch the sciatic nerve. So this is the tendon of adductor magnus, which is clearly palpable just anterior to gracilis. And then we put a right angle forceps to go around the tendon of adductor longus. This is easily identifiable because it inserts into the adductor tubercle of the distal femur. So it doesn't matter. A lot of people ask me in what amount of knee flexion this tendon transfer needs to be tension. The amount of knee flexion is not really critical because this is a soft tissue to soft tissue transfer, and the tension will adjust. The tension is only important when you're doing a tendon to bone transfer. And one more stay suture is applied, which goes through the semitendinosus and then through the adductor magnus. So another point is that one should not do, after releasing the hamstrings, one should not do a popliteal angle. So you should not stretch the tendon, you should do it in a very gentle manner. So after hamstring surgery, we can allow the child to weight bear as tolerated immediately after surgery. We do it as little as 2 to 3 days after the surgery. A knee gaiter is used at night for 8 hours for a period of 6 weeks to 3 months again. Gaiter is always used for standing during the day until quadriceps control is regained, and unsupported weight bearing. Without a splint on the knee, you should not allow the child to weight bear unless until they are able to get complete extension of the knee in standing, because it's very common for children to go back into the flexed knee position again, and it takes them a long time for their brain to readjust to this new pattern of weight bearing. So it's important to emphasize to the therapist that they should keep some splint on the knee until the child themselves can lock the knee in full extension and stand, and only after that we allow them to start weight bearing. And anti-gravity muscle strengthening exercises have to be continued for at least 1 year after surgery. So thank you very much for your attention.
Excellent, Jayanth. Thank you.